Hi, my name is Nancy Flowers. I'm the Dementia Project Manager for Rainbow Hospice and Palliative Care. Today we're going to talk about guidance with decision-making at the end of life. Most of us, when asked, would say that we would prefer to die at home. Yet only about a third of us have left anything in writing saying what our wishes are, where we'd like to die, and what kind of care we'd like at end of life. That percent increases with those people who are 60 years of age and older. About half of older adults have some kind of advance directive. When it comes to hospice patients, 88% have an advance directive that they have completed saying their preferences. However, when we look at our medical records, only about 50% of our patients have an advance directive in their medical record. What's the lesson for us in that? We need to ask to see the advance directive and to make sure that we have a copy of that in our files. So what you'll learn in this module today is the importance of advance directives, how to have a conversation about some of the difficult topics that families have to grapple with, like CPR and tube feedings. We're also going to talk about the types of advance directives and what resources are available for you as staff in completing these advance directives. So what is an advance directive? It's a written statement about your wishes for your medical care and your end-of-life care. Anyone 18 years of age or older can complete an advance directive. There are many benefits of completing an advance directive. The first and foremost is that this is a guide for caregivers and medical providers about the kinds of care you want. It allows you to make decisions about your care preferences during a non-crisis time. Advance directives allow patients to receive only the care they want. They minimize the risk of confusion or disagreement about the choices a person would want made on his or her behalf. They're important because unexpected end-of-life situations can happen at any age, so it is important for all adults over the age of 18 to prepare these documents. There are barriers to the completion of advance directives. They may include cultural, religious, and personal views and fears about discussing end-of-life care and death. Some of us may be concerned that if we talk about these topics, that somehow it makes them real, almost as if we had a superstition about talking about a topic, making it more real. Some of us may defer to medical providers believing that they know best and will make that decision for us. These are subjects that are very difficult to discuss. We may fear that these discussions may upset the people around us. We may worry that they will upset the person who is receiving the care or others in the family in talking about end-of-life care and the decision-making that needs to be made at that time. A story that comes to mind is one that was told to me by a social worker a few years ago about a patient and a family that she was working with. This was her first visit out to see the patient, and the family pulled her aside and said, "Please don't tell Mom she's in hospice. It will just distress her." So the social worker went to meet with the patient. The patient asked her to shut the door, and then proceeded to ask the social worker's help in talking to the family, because the patient realized that her family was really struggling with how best to handle her dying. So when should we start to have the conversation with patients and families about their end-of-life preferences? Certainly those patients who are in hospice, we need to start on the admission visit and then continue that conversation throughout the care process. If you know that a family is having a difficult time making care decisions, it's very important that you meet with them to discuss their concerns. If you don't feel you're the right person to have that conversation with the family, or you see that there's somehow you're running into barriers or problems, use the rest of the hospice team to help you in having that conversation. Talk as a team and decide who is the best person to have that conversation with the family. You're also going to want to think together about what kind of education does the family need to help them in making some of the very hard decisions they have to make.
One of the roles of my job is to help with all the documents that we deal with, whether that's the post, whether that's end-of-life planning, whether that's power of attorney paperwork, public aid applications, all those different kinds of logistical things. So some of our people have had lots of experience at the hospital, so the post is familiar to them. However, some people have never talked about, what do I want at the end of my life? You know, what does mom want at the end of her life? And so I try very much to just make it kind of matter of fact but comfortable. It's just something we need to talk about. It's not good or bad. I try to make it as comfortable as possible. And I walk through it with them. I don't ever hand a patient the paper or their family member a paper and say, you can fill this out. I usually walk along with them and we go through it together. So we can answer any questions, so we can talk about, the pulse is really important because we need to talk about, does mom want feedings? Does she want any extraordinary measures at the end of her life? And it also gives us an opportunity to talk about what's hard about that for the son or the daughter or the child or whoever is caring for them, because it gives me a much better picture of really what are the things they're struggling with. I have lots of family members who don't agree with mom or dad's choice, and some of them are able to honor that and respect that, and some of them struggle with that. And so it gives us also a different part of that relationship to kind of work through, and gives me a clue, a little picture of some things that we might need to talk about. And since we've had this conversation about this very black and white paper that they knew we needed to do, it's opened up a door that might not have been opened up before.
As you think about the best ways to help your patients and families approach care decisions, think about your own feelings and reactions to the care situation. They can trigger responses in ourselves, and so it's really important to know what our own feelings are about the care that we're providing and the decisions that are being made. A patient situation that comes to mind was a 23-year-old young man that we cared for a few years ago. He had been diagnosed with a terminal disease a few years before and had fought very hard to survive his diagnosis. He was hospitalized repeatedly during his illness, and at one point after his admission to hospice was admitted to our inpatient unit. I was covering the inpatient unit that day and was asked to assist this young man with a do not resuscitate order. I need to tell you a little bit about myself. I have a 26-year-old son. And as I was thinking about going in to help this young man complete a DNR and going in to talk with his father, who was probably the same age as my husband, it did give me pause. And I needed to think for a moment about my feelings in reaction to his story. And then I needed to put them aside so that I could go into the room and help this family complete an advance directive that they had probably hoped they would never have to complete, or certainly not when their son was 23. So let's talk about some of the topics for which we provide guidance and education for families. CPR, hospitalizations, and artificial feeding, amongst others. It's important that we remember as we have these conversations that every culture, every family, every faith community has within it their own distinct views about how they view end-of-life care and medical care. And no matter what those beliefs are, we need to not only respect their beliefs, but we need to understand what they are so that we can better help this family with the hard decision-making that faces them.
As patients near end of life, the end of their journey, you start to see the subtle changes, and that's when you bring the family together. You always want to know what would mom or dad or grandma want? If it were them talking to me, what would they want? And you have to take into consideration customs and traditions and nationalities because they so become important in the way you formulate your plan of care.
I think what you said is so important about asking what the patient themselves would have wanted, because oftentimes the family have a difficult time knowing there's an infection. Should we use an antibiotic? There's some other kind of problem. They're not eating. Should we use a feeding tube? But just asking them, what would this person have wanted? It's always wonderful if there's a living will or they've made their wishes known, but asking them, have there been conversations? What do you think they would want? Is this the way they would want to continue their lives? Would they want to continue living like this?
The families in and of themselves are often difficult because they're not in agreement with what mom or dad would have wanted. You always want to get to that discussion about the final steps of the journey. However, we have to deal with today and how we're progressing through this. We need to be very tuned in to every family member and what would they like to see. It's never about us, it's always about that patient. It has to be, our goal has to be, end result, how we can do quality of life and comfort and symptom management for that patient, which as you progress through this, you find how quickly you become a family member that they trust you. And once you've elicited that trust, they know that if you say you'll be there Tuesday, you're there Tuesday and you're going to settle the dust. My job is to make sure that they're comfortable and have what quality of life they're used to or as close to as used to as possible. If it involves wine at dinner, so be it. If it involves trying to get, grandma okay to take her outside on the deck because she enjoyed that, so be it. We've made arrangements to have patients go out of town, to be at weddings, to be a participant. And granted, it's not going to be for the 8-hour wedding ceremony, but it's to just be there for that picture. And that's that final memory that no one can take away from that family member.
And I really agree with that it's really a wonderful opportunity to have, to help bring some joy for the day, to engage in humor, if that's possible, even in the difficult circumstances. You're mentioning glass of wine, if that's what their custom has been. We've put some beer on a tooth that and given that to a patient, or a drop of chocolate as their eating is decreasing. No, they can't eat a full meal, but if there's a favorite dessert or a chocolate pudding or something that just even a bite or a taste that brings pleasure to them, if they enjoy music, just singing a song with them or for them, and letting the family engage and see that it is about bringing joy or emotional well-being to them, not just the physical.
Absolutely. What I try to do with families early on is encourage them to maintain a sense of humor. Dementia is one of the most taxing diagnoses because that patient can't say, I hurt, I'm uncomfortable, I want this over, I'm done. That you're never going to hear that. You're going to read that from their face. So when you're alone with that family and they'll say, oh, my mom did the stupidest thing yesterday, she put socks on her hands. You have to laugh at that. She knows they're socks. She just doesn't know where they go to. And this is all part and parcel of this disease. It will change tomorrow. It may rebound back to a time of real good memory. Work on that. Run with that. Don't be afraid to go back in history and let them talk about a time that they really are sharp on. But don't argue with them. If it's Tuesday, it's Tuesday. If their name is Jill, their name is Jill. It is what it is until it isn't.
And I would like to say that we have some excellent resources on the F drive. I believe I've made photocopies of several of them. And as you were saying, don't argue with the person, different ways to converse with them. There is a handout that is excellent and actually helped me in dealing with a person with dementia. So you don't ask them, what did you have for lunch? You might ask them, how was lunch today? So they can answer that. Oh, depending on their verbal skills at that point. But again, it gives very helpful hints and helpful to the family who might try to bring back reality or create tension and confusion and anger within the patient, frustration. So that's a good point. And going back to one thing that you said, that different family members may be at different places. Certainly we see that very often, oftentimes out of town families or families who aren't there on a daily basis with caregiving, don't understand what is going on. So our part in helping them, whether it's making a phone call to the person who is out of state and helping them understand what's happening, and knowing that we're all a work in progress. So gently helping them come to realization of what's going on. As I work with patients facing some of those questions about the possibility of a G-tube or antibiotics when someone has an infection, wondering about a DNR, there is an excellent handout, again, that we have on the F drive, and it's put out by the Alzheimer's Association. So it's not just Rainbow Hospice saying, hey, we think this is a good idea, but it's promoted by the Alzheimer's Association. And in fact, they had a physician do a research study to see if some of these different things were actually helpful and beneficial to a patient with dementia. The G-tube, as you were mentioned, discusses the terrible burdens that puts on a person. Allowing natural death, I like to call allowing natural death rather than a do not resuscitate, but how that's really a more appropriate decision for someone with dementia. So using these handouts, of course, I would explain things to the families, but sometimes they like to have something to hold on to after I've gone, or again, as other families members come into the home, that gives them something to read and a reference to utilize as well.
Let's talk about CPR. CPR is not always in a patient's best interest. Only 15% of patients who have been hospitalized and who have CPR survive to be discharged. Many of those patients may require intubation and ventilation prior to death. This is contrary to the experience our patients and families see on television, which is that people who have CPR survive. This requires extensive education on the part of our team to help families in making a more informed decision about CPR on admission and throughout the hospice process. Let's talk about tube feedings. If advanced directives are in place, they will likely include some information on feeding. When the body starts to shut down, difficulty swallowing begins, and organs that are essential to processing the nutrients from food also slow down. This is important for our families to understand and receive education about. Fluid can build up in the lungs, the abdomen, and legs or buttocks, causing discomfort where none was intended or desired. I'd like now to talk about a patient that we cared for who was in a hospital setting, had been recently admitted to hospice, and part of his nutritional support was coming via tube feeding. The family was struggling with the decision to continue or discontinue tube feedings. And when conversation came up with them about their wishes, they expressed a strong opposition to do anything because, as they put it, I don't want to be the one that's responsible for my father starving to death. What helped this family in making a decision about that was providing information about what they were seeing at the bedside, which was that their father was congested, was coughing, was having trouble breathing because of the fluid buildup in his lungs. Providing that education to the family allowed them to make a decision to reduce the tube feedings and increase their father's comfort at end of life. Let's talk about patient rights and advance directives. Since 1990, federal law requires that we inform patients of the availability of advance directives on admission to any healthcare setting. Not only are we required to ask them if they have advance directives, but we are required to offer them assistance in completion of advance directives. No one can require a patient to have an advance directive. It's also important for families to know and patients to know that advance directives can be canceled at any time, either verbally or in writing. At Rainbow Hospice, it is our policy that we will assist patients and families with the completion of advance directives. So let's talk about the types of advance directives available to support our patients and families in their care. One that is very familiar to you is power of attorney for health care. It's also power of attorney for property, 5 wishes, declaration for mental health treatment, the do not resuscitate order, the POLST, which is a provider orders for life-sustaining treatment, and the living will. So let's start with talking about the healthcare power of attorney. The healthcare power of attorney allows a person to give healthcare decision-making authority to another person who is referred to in the document as the agent. That agent can be anyone the person trusts. It can be a family member, it can be a friend, anyone whom the person believes will act on their wishes and their preferences for care. Resources will be available to you on the F Drive that will help you to help your patients complete these forms. In addition, links to those documents will be available on the F Drive as well. The power of attorney for property document, like the power of attorney for health care, allows a person to select another person to make decisions for them. In this case, it's to make decisions regarding assets, finances, bank accounts, real estate, and other types of property transactions. This agent can be anyone that the person trusts to make decisions. Again, it can be a family member, it can be a friend, anyone that the person is comfortable with. Unlike the power of attorney for health care, this document must be notarized. The mental health directive is a very unique document, and you may not complete this much in your work here at Rainbow Hospice, but I wanted to include it because it may be useful to you at some point. This is a document that indicates preferences for future mental health treatment. What is unique about this document is that while the other powers of attorney can be revoked at any point, this document can only be revoked when the person who has executed the document is judged to be psychiatrically stable. I wanted to share a story about a resident who completed one of these documents. This was a resident who was living in a psychiatric nursing home who had been diagnosed both with cancer and bipolar disorder. This document allowed her to indicate her preferences for care, while also acknowledging that when she was in a manic episode, she was less able to make sound decisions about her care, and indicated in the document that she wanted her agent to be able to make those decisions for her at times when she was not able to do so. Let's talk about the DNR and POLST. Both documents are similar in that they're medical treatment orders, but they also have slight variances that I want to go through now. The DNR's primary focus is on CPR, cardiopulmonary resuscitation. This document is signed by the patient or their legal decision maker, a witness who can also have completed the document, and the physician. It's important that this document and the post be dated. We have had nursing homes reject the document when it lacked the date that the physician signed the document. The post is an alternative to the DNR form, but is more elaborate, includes more information. So the post includes information on CPR, but also includes information on intubation and mechanical ventilation, as well as comfort measures, antibiotics, and artificial nutrition and hydration. This document is also signed by the patient or their legal decision maker and the physician, and it's witnessed. The form also includes a place to insert the name of the patient's healthcare decision maker on the back and information on how the Healthcare Surrogate Act works, if that's needed information. I wanted to talk now about the real-life use of the post and how helpful it can be to a patient and family making these decisions. A 53-year-old woman with advanced MS was having conversations with her husband about her end of life. She was really struggling with some of the decisions about feeding and wanted some assistance in writing those decisions down. So she asked for my help in helping her complete the document. It was very easy for her to make the decision to choose non-resuscitation if her heart stopped or she stopped breathing. But she struggled with the decision about feeding because she was the mother of a young child. So what we did is we talked about at length her wishes and under what circumstances she wanted to be fed. And so we noted those. We noted that for her, if she was alert, she wanted to be able to make the choice to insert a feeding tube, if that made sense at that time. She also noted on the form that if she was not alert, if she was not able to make decisions, she gave her husband permission to decide to not insert a feeding tube if that made more sense at that time. Let's talk about living wills. This document communicates a patient's preferences about death-delaying procedures. The document can include language forbidding the use of various kinds of medical treatments and applies if the person has a terminal condition. The document does need to be witnessed by 2 individuals and can be written on a standard living will form or one that is written up, created by the individual. An important thing to remember about this document is it does not designate a person to make decisions on behalf of the patient. Let's talk about the 5 wishes document. This document includes language about end-of-life preferences. This document can take the place of a power of attorney for health care and a living will document, but also can be used in conjunction with both of these documents. This document includes language about personal, emotional, and spiritual concerns of the person completing it. And the 5 wishes document is a great way to structure a conversation with families and physicians about the person's end-of-life preferences. A story that illustrates the effectiveness of the 5 wishes document in capturing personal preferences is a story of the 53-year-old woman with MS that I talked about earlier. This woman was really struggling with how to communicate her wishes to her husband so that he would be able to act on her wishes when she was unable to talk with him anymore. The couple sat down with this document and used it to plan not only her memorial service, but to record the legacy she wanted to leave behind for their 9-year-old daughter. Now what I'd like to talk about is what happens when our patients have not written down their wishes in advance of their decline in dementia. In 1990, legislation was established that created the Healthcare Surrogate Act, that created a process for family members and friends to be able to step into the decision-making role when no decision maker had been established. There is a priority order of decision makers that starts with the guardian of the person, then goes to the spouse, to adult children, and so on, designating which person in that order can make decisions on behalf of the person at end of life. The decisions that the surrogate decision maker is allowed to make include withholding of life-sustaining treatment, the execution of a DNR or a POLST, and other end-of-life treatment. If there's a disagreement within the family about healthcare decision-making or financial concerns, a guardian can be appointed by the court. There are significant costs to this as it is a legal procedure, but once established, that person can then make decisions for the disabled person. I'd like to share an example of a story as to why guardianship can be a useful tool in helping a family make decisions at end of life. This story involves an 80-year-old gentleman with an advanced neurologic disorder that prevented his ability to communicate his wishes to his family or the care team. His primary caregiver was his wife of 60-some years, a woman who had been a nurse in her prime but now was exhibiting signs of dementia. As her dementia progressed, her ability to provide care for her husband became seriously compromised. Fortunately, there were 2 adult children in the picture, but both of them had been hesitant to become involved initially because their mother had such strong opinions about their father's care. We provided a great deal of education to the adult children and assisted them in looking at their options and the role they wanted to assume in their father and mother's care. We provided guidance about legal resources, we provided guidance about the guardianship process, and ultimately the 2 daughters decided to pursue guardianship for their parents and were able to step into the decision-making role that both parents so greatly needed. When there are no advance directives, this can be a very stressful time for family members and can cause concern and pressure on them to try to understand what their parents would have wanted in the absence of written documentation. So what can help a family is you, the hospice team, providing information about the patient's condition, the diagnosis, and the expected prognosis for the condition. Asking the family about previous conversations they've had about care preferences and wishes will help the family begin to think about earlier conversations and perhaps help them better understand what their relatives would have wanted them to do had they had written documentation. It can also be helpful to talk with family members about any faith rituals or cultural practices that would have been important to the patient and that would need to be followed in end-of-life care. Of particular importance would be talking to the family about any rituals that would need to be done at the time of death so that hospice staff are better prepared to be able to assist and support the family in these practices and rituals. Let's talk about hospice staff role in helping the family understand end of life in hospice. Your primary role in supporting families is to provide guidance on what end-of-life care is going to look like and hospice's role in supporting that. You'll be providing education about comfort care, the role of the interdisciplinary team, and the benefits of each of the team members in supporting the family. And you're going to be helping the family to identify any fears that they have about end-of-life care and helping them develop the plans that will allow them to feel comfortable in providing that care. Those plans might include, who does the family want to be there with them at end of life? Do they feel comfortable providing the care in the current situation they're living in? Do we need to consider hiring additional support, considering long-term care placement, perhaps even a move to the inpatient unit for care at end of life? Those are all the kinds of plans that the family will want your support in helping them develop.
In dementia, I think one of the things that every family is coming from a different perspective. They're coming from a different place. Some people have lots of knowledge. They've gone online, they've gone to support groups, they've talked to all their friends, and they have a large knowledge base. Some of our people have almost none. They have no idea what to expect. They have no idea what to anticipate. I find that both sets of people tend to have some assumptions that get challenged because head knowledge is not always the same as experiential knowledge. Most find that while they want to care for mom or dad or grandpa or whoever, it's much harder than they expected at some point. When they can still be at home by themselves and you can just pop in for lunch and make sure they got their meds, that's much easier than when they get to the point where they need assistance all the time and they can't be left alone. And it changes their lifestyle, which most of them, they assume but don't realize how much. And this process is often longer than most of our families anticipate in some ways. It's different than some of our other illnesses that have a shorter duration. This tends to change your life for years, and I find that that's a big challenge for many of our people. Most of them don't anticipate how hard it will be to lose pieces of their loved one, a piece at a time. I was with a woman yesterday who was just saying she misses cooking with her mom in the kitchen. And it wasn't any big thing, but that was something they did often. And it was a big part of their relationship. And now they used to talk during that time, and they don't have that anymore. And she accepts it, and she understands it. But it was really important for her to be able to say that out loud to somebody who would understand. Because her friends, they understand kind of, but not completely, because they haven't been there. They haven't watched mom change to somebody who used to run the world, used to run the house, used to run their family, to really not being able to do much of anything except straighten her blanket. That's what she does all day. And so helping people be able to grieve those things, because there's a grief process that happens along the way. And yet, when they finally do pass, oftentimes families assume that they've already done all that grieving, and they haven't. And then many times it's harder than they anticipated. They feel some guilt because they're relieved, because it was hard and difficult, but it also hits them harder than they thought, because even if they didn't have mom fully, they had her for a while in a way, and they could hang on to that. So managing some of those dynamics, I do talk with families as we're going through the process about some things to anticipate that some people experience. You may or may not, but sometimes just knowing helps them to be able to talk about those things. And I think the challenge really for us is to be able to be there with them in the midst of that, because it's not always comfortable for us either. You know, it's sad. So making it okay to talk about it and say it out loud to someone who actually understands what you're going through, I think is the thing that we offer the most to families.
In summary, we know that these can be difficult conversations to have with families, but they are very important, both to the family, but also to you in developing a plan of care that will best support this patient and family at end of life. If you need additional resources in developing that plan of care, know that you can turn to your colleagues on your team, as well as request a dementia consultation to help you in developing the best plan of care for your patient and family at end of life.